I'm Dr. Pilar Pichon. I'm by training, I did my training in child neurology at Loma, and then I went on to do my epilepsy fellowship at Emory University in Atlanta. And I came back to Loma. I have been there for 4 years. So in the past 4 years that I've been there, we've done about 16 epilepsy surgery on my patients. I have 20 active ketogenic diet patients and modified Atkins, and then I have about 30 VNS patients. So I will be talking today about drug-resistant epilepsy. This is a totally informal talk. You feel free to ask me questions. And just as a starting point for us, drug-resistant epilepsy by definition comes in many names. Some doctors call it medically refractory epilepsy. You have the drug-resistant epilepsy. And we call them the International League Against Epilepsy. They're like our superheroes. They define drug-resistant epilepsy as a failure of 2 adequately dosed and appropriate drugs for the type of epilepsy, in my case, of that child. And I don't know if you have family members who are adults also. So it only takes 2 medications, and then after that, the likelihood of a 3rd, a 4th, a 5th, any subsequent medications helping becomes as low as 3 to 5%. And this is from a study that was done by Kwon and other people. And it's been pretty consistent, and I see that as well. I've seen it in Atlanta, and I've seen it here at Loma. So after you fail 2 medications, it's very hard to have the seizures resolve with another medication. So do you have any questions for me or comments?
Can you talk about maybe some alternative therapies or?
Sure. Like do you have any specific question?
Restorative yoga or massage or something like that?
Massage. So what happens with epilepsy, it's not just the seizures. You have other what we call coexisting or comorbid conditions. So an example would be anxiety. That's one. Difficulty sleeping, especially for children or patients who have seizures at night, and then the seizures wake them up. And then from all of this, you could also have stress. So my primary goal is let's treat the seizures, and then let's find out what the triggers are for the seizures. Some parents have told me that one of the triggers for their child is actually stress. So let's say you put them in a new environment, or you bring them to a party, they get stressed. Or even as simple as tomorrow is your party, it's your birthday tomorrow. They tend to have seizures the night before or the night after the birthday. So once we treat the seizures and we identify the triggers, then I ask the parents, what have you tried? Let's say if a trigger was stress, what have you tried? And some parents say, well, breathing exercises, stress management. And so do they work? Do they not work? If they work, then I say, let's go for it, let's practice it. And I have referred patients for cognitive behavioral therapy to help them with it. So the other coexisting condition is headaches with seizures. So I treat the seizures and I treat the headaches, and certain medications can treat both the seizures and the headaches. So if there's no contraindication, an example that I can give you, for example, is Depakote, and that helps them. With regards to your question about yoga, there have been functional MRI studies that says the brain waves actually change once you get into this yogi state. And it calms you down, and it almost mimics the slow wave sleep. So the reason I know this was when I did my fellowship, I was actually studying children with electrical status epilepticus in sleep. And I was trying to see their patterns when they're sleeping. And then, because as soon as they fall asleep, they go into slow wave sleep, then they seize. So my thought was, if there's a way for us to help with the sleep, let's say some children need to calm down, need to have exercises, need to have yoga before sleep, before falling asleep, then I think that doesn't hurt. So we could definitely try that. I hope I'm answering your questions, right? I've had families.
I know it's not usually addressed.
So I've had families try tinctures, you know, little solutions that they buy, tungsten, zinc, whatever, esoteric things. So I tell them, make sure you know, number one, where you're getting it from, and know exactly what's in that bottle that you are giving your child. Because especially if you're giving it for the child to take, so you have to know what's in it. And then most commonly we call it artisanal CBD. So the CBD that we get from the dispensaries, I always remind the parents, you need to go back to the dispensary, get an official lab report of what's in the bottle that you got for your child. Because we need to know what's in it, not just the percent CBD, but there are different types of CBD, there are different types of THC, and you could also have contaminants. So we need to know what's in it. I think that's your role as a parent, for example, is to know what you're giving your child. Ketogenic diet, it's one of my favorite topics. So if the medications have failed, oftentimes I try to see if there are any contraindications to ketogenic diet. So if there's a metabolic disorder, for example, you definitely can't give ketogenic diet. In simple terms, it's a very high fat ratio. So if the person cannot break down the fat properly, if there's an abnormality in any of the enzymes that's involved in that pathway, then you don't give them ketogenic diet. So it's unlike the fad diet where you could get on, you could get off on the weekend, and then get back on the week. We can't do that for our patients with epilepsy because any changes can really mess up their seizure control. So number one, I urge you to go to a center that has a dietitian and an epileptologist and strong nursing staff who can facilitate you in the screening for the diet, and if there are no contraindications, they could initiate the diet. And for our practice is we admit you at the hospital for at least 4 days, because we go up slowly on the ratio and we make sure that all your labs are within normal limits, you don't get too acidotic when you're on the ketogenic diet. And then if everything's good and the families are well educated, you go home on the 4th day or the 5th day. So ketogenic diet, it's very helpful, but it's also a lot of work, a lot of commitment. Yes? What was in the cookie?
We don't even know.
You don't know?
We got home and she told us, yeah, they gave you a cookie. And they told us they weren't doing snacks. So obviously that's another issue. But how bad is that going to affect her?
What ratio is she on?
Even though we just started the modified Atkins.
Okay. So modified Atkins is more forgiving. As opposed to the classical high ratio diet, because you do get some carbohydrates with the modified Atkins. So I actually just stopped by the Phoenix Children's table. They actually have an app now for the keto. So what you can do is, number one, you call the epileptologist or the nurse and let them know that my child had a cookie on Sunday. You call them on Sunday, especially if your child is on a classic keto diet. And then what they'll probably ask you to do is either come in or you check the ketones, and they will ask you, do you notice increased seizure frequency? If you do notice increased seizure frequency, then it's better to go to the emergency room, because this is a Sunday. And if you are on a very high ratio, the 4:1, what I usually want to do is to look at the BHB. So that's a blood testing for how ketotic the child is. So if I could see that the BHB has gone down dramatically and increased seizure activity, then I may actually bump up one of the medicines just to get you through that increase in seizure frequency. Or if you are on a lower ratio, for example, a 2:1, 3:1, I may bump up temporarily to 3.5:1 or to 4:1. It is, I tell families it's very serious, especially if your child is on the classic keto diet at 4:1 ratio. Because I have seen children, not here in Loma Linda, but at Emory, where the child went into status epilepticus after getting a birthday cake from a classmate at school. So she had prolonged seizures, but she was on a classic 4:1 ratio. Okay. Hi. Any other? Yes?
Can you comment on using the ketogenic diet?
For adults? Sorry, let me just turn off my pager. For adults, the ketogenic diet is a challenge if you do the classic. Because number one, adults can walk to the fridge, grab what they want, drink a beer, drink a soda, so that's for adults. And then number two, we're so used to knowing the taste of all these varieties of food. But the Johns Hopkins University, they have a big ketogenic diet center for both children and adults. And what they found was that in adults, it's actually the modified Atkins diet that is more palatable and that the adult people can work with. I wish I had a dietitian here. Yes. Does that make sense?
Yeah.
Yes.
And what kinds of seizures is it best for?
So most of I think for the drug-resistant epilepsy. So if you failed 2 drugs, then definitely I would consider ketogenic diet. And for specific syndromes. For the children, for example, I've seen it work for Lennox-Gastaut, Dravet syndrome, even infantile spasms. So we usually still do the first-line drugs, and if that does not work, then we consider the ketogenic diet. So those are the syndromes. But in terms of adults, it can work in focal epilepsy. It can work in generalized epilepsy as well. So think of ketogenic diet as another medication. You have to follow it. If you miss a dose or if you miss the proper foods that you have to let your doctor know so that we can make adjustments for you. Yes?
How long do you know the food they eat has to do something with their condition?
For ketogenic diet, for example. So in certain centers, we actually, if they've failed already usual medications, and sometimes when they go into what we call status epilepticus, seizures longer than 5 minutes, and you give them the big guns already, anesthesia medications, and still they continue to seize. So that's when sometimes we do consider ketogenic diet. And in that instance, we could try it up to 2 weeks to see if the seizures stop. If the seizures do not stop for 2 weeks, when the person is in, or the child is in status epilepticus, then we consider it a failure. But in the clinic setting, for example, you've already tried at least 2 medications, there are no contraindications to ketogenic diet, then you could try the diet, you initiate the diet, and I like to keep the diet on for 3 months. And we're very strict with a food diary. You write down what you give the child, or if you're the patient, what you take, both liquids, solids. And then seizure diary. So you write down how many seizures you have every day, so we could track things. And then if you're on the classic ketogenic diet, I also check the urine ketones, and I check the glucose, the sugar, because I don't want you to get too low on the glucose. So if it's below 50, we do a rescue for you. So 3 months. If it makes a difference, you continue it up until 2 years, and then if it does not make a difference, you discontinue it in 3 months. And it has been shown in studies in children that the anti-seizure effect of the ketogenic diet lasts beyond the 2 years that they're on.
But the diet has more relationship to the medicine, the medication, than the condition.
I think it works both ways. If you ask anybody, any of the experts in ketogenic diet, if you ask them, how does keto work? They will have different answers, or if they're honest, they will tell you we don't know. Because some people think it's because it's through the mitochondria, which is the power cell. Think of it as like the gas tank of the body. So it uses the ketones, and then that powers your cell. So if you kind of quiet them down, you quiet down the seizures. That's one thought. But then another new thought came, for example, at Boston Children's, they started the low glycemic index diet. So these patients they just eat foods that have low ability to make your blood sugar shoot up. And so they don't have ketones, but then you also get glucose control. So they're thinking maybe it's more the sugar that's pro-epileptogenic, and if you take out the sugar, you control the rise in the glucose, then you don't have as much seizures. So that's one other. And then the other one, they think it's anti-inflammatory. So it works in different ways, right? And I have seen it work very well with certain medications. So I don't think it's been published, but I've seen it with some of my kids who are on clobazam, on Onfi. They tend to do better with the diet.
Which diet? All of them?
The ketogenic,
The keto.
classic keto, yes. Yes?
How do you choose between classic and modified Atkins?
So age is very important. If the child, and the syndrome of the child. So if the child, for example, has a G-tube, it's so much easier to do with a classic ketogenic diet. But for example, if they eat by mouth, and if they can walk and open the fridge or beg for food, then sometimes modified Atkins. And if that doesn't work, then I consider low glycemic index diet. And the most successful diets that I've had is when the whole family goes into it. So I have a few families that are doing modified Atkins diet, the whole family, because the mother only needs to cook once. Right. It's a lifestyle. Yes?
Why do you only do it for 2 years?
That's a good question. So one of the side effects is, which is desired in the popular literature, is weight loss. And then the other thing is bone loss. So, and you can also get deficiencies, so something like selenium, vitamin D. That's why we bring you in, because I check the levels of all these micronutrients, and then we put you on supplementation. So if you don't need it beyond 2 years, then we don't keep you on it. But I know it's challenging when some of my patients graduate to the adult centers because not a lot of adult centers do ketogenic diet. So some of my mitochondrial patients, for example, I know that their mitochondria has not changed. So they will need the diet. So I encourage them to continue the diet. And adult epileptologists have tried to wean them off the diet, and they have increased seizures. So sometimes if I can still see them and my dietitian can still see them, then we help them out and we continue the diet for them. But there's always a challenge because you switch to Medicare. So in California, from CCS to Medicare, sometimes it's hard to get the formula approved. But it can be done. Anything else? People always ask me about CBD. I think they Google me and then they see my name on the paper from last year about Epidiolex. So Epidiolex is an FDA-approved CBD formulation. The amount of CBD is 20 milligrams per kilogram. So it's pretty strong, very strong compared to what we call the artisanal CBD, the CBD that you get from the dispensaries. So some families, they're used to what we call the artisanal CBD, and they swear it works for their child, and they've been using it for a while. So you know your child best. I'm there with you once every 2 weeks at most, once every 3 months. But you are with your child day and out. So I listen to you. But then we also have an agreement that first they have to get the report of what's in the artisanal CBD. Number two, if they change even just the bottle or the dose, they have to let me know. I do not dose it. I do not recommend it. But if they use it, then they need to find someone who could guide them with the dosing. But if they use the Epidiolex, which is the FDA approved, then I follow the guidelines. Usually I start at 5 milligrams per kilogram per day, and then I go up slowly up until the 20 milligrams per kilogram per day dose. So I know that the CBD works in so many receptors that the best effective dose for the patient is where I will stay. I will not push it any further if their seizure control is better. Or if their seizure control is worse, I will go down in the dose, or if they have side effects to it, like high ammonia, then I will take them off of Epidiolex, or advise them to get off of the CBD. And the CBD can interact with the medications. So one of the most common medication that it interacts with is clobazam, Onfi. So it increases the clobazam level. So be very careful. If you started CBD on your child and your child is sleeping all the time, then definitely call your doctor. And in rare instances, I have seen increased seizure frequency with the CBD and the Epidiolex. So in our extended access program, that was actually one of the most common side effects, the increased seizure frequency and possible infections also, because it suppresses the immune system. So you have to be in constant communication with your doctor to keep track of the side effects. Yes?
Have you heard of the CBD oil affecting the frontal lobe for a younger child?
Is it THC or CBD? Right. So there are so many CBD receptors in the brain. CBD1, CBD2, CBD3, A, B, C, and the other, the cannabinoid system is one of the most complex systems in the brain. It affects the frontal lobe, it affects the temporal lobes where memory is, it even affects movements, you know, like in Parkinson's disease, in tremors. So I think there is truth to the CBD affecting the frontal lobes because there are cannabinoid receptors in the frontal lobe. But it's not just the frontal lobe, it's the whole brain and the rest of the body. We don't know. We don't know. In certain syndromes, we have seen that the CBD helps control the seizures. Dravet syndrome, Lennox-Gastaut syndrome. Yes.
He had tried a dispensary type CBD, and I don't know if I noticed a huge effect, but then the hospital was like, well, the Epidiolex was so much stronger. But when we tried Epidiolex, she keeps breaking out in a rash every time we do it. Like,
With the Epidiolex?
and they weren't really familiar with that, so I feel like I didn't want to give up, but for some reason the dispensary one, she didn't break out in a rash. And yet Epidiolex, she does.
What other medications is she on?
Depakote.
Depakote.
I'm supposed to do Omvi, but I haven't done
Okay.
Omvi yet.
Not Lamictal, right? No, okay. So the Depakote, what I have seen is hyperammonemia with the Depakote. I haven't seen rash with the Depakote with the Epidiolex. How high was, did they push the Epidiolex? 5 mgs or 10 mgs? Was there a rash at 5?
Oh, so we did do that, and I did, but it was less. So she felt itchy all over, and then she had the rash on her legs. So we went down to the 5. I stopped for a week and then went down to the 5, and it was smaller. But I kept trying to go because I'm like, maybe it'll just go away. And it was spreading and starting to spread on her face, and I'm like,
So you had to take it off.
yeah.
Right.
It's not.
So if it's an allergic reaction, the second exposure to the allergen is even worse than the first. So I would try to go down on the dose, but if the rash stays, maybe it's not the best medication.
Because it just was weird that the CBD dispensary didn't cause a rash. So I thought, which one? I was trying to figure out what the ingredients. I know Epidiolex is made like has sesame oil, and I tried sesame oil by itself, but I'm like, I know she has sesame oil. It didn't seem to. It's like, darn it. I'm like, what is? But I wasn't sure. I mean, I know you guys can't promote necessarily a medication that you can't prescribe.
Right.
I feel like maybe I should go back that and try some other ones.
Speak with your epileptologist. Yes. I think the mindset has changed, so they might have more experience with the artisanal CBD that you are using. Right. You're welcome. Yes.
Is there a relationship between Epidiolex and the Keto diet? Patients on it?
So I have this handy dandy table that was a compilation of all the results of the studies from Epidiolex on how it will affect the different drugs. But there's no ketogenic diet there. So my experience with Epidiolex and ketogenic diet is I haven't seen it affect the diet in terms of the measurable things. I haven't seen it affect the BHB or the glucose or the ketones. But I don't know if the artisanal CBD can affect the keto diet, because I haven't done a direct study for that. But that's a good question. Yes.
For patients who really saw that increased on CBD, what is the similarities, whether age or
THC. You're right. The presence of THC in the artisanal CBD. Right.
The presence, you said, increased the seizures?
Yes. Right. So I try to advise the parents, if you get the artisanal CBD, make sure you try to get one without THC.
And then there's all these numbers,
Right, there's,
full spectrum.
like THC 1, 2, or THC A, B, right? So. We're asking a lot out of the parents and the patients too, especially the adults, right, to research. It's just the nature of the healthcare. I think one of the speakers last year said, the horse is out of the barn already, but we haven't kept up. So we all need to keep up with the data. We have the data for the Epidiolex, but we don't have the data for every strain of artisanal CBD that's out there. So always just be safe for you and for your child. Epilepsy surgery. Any questions about epilepsy surgery? So that's also one of my passions. Out of the 16 cases that we've done, most of the temporal lobe epilepsies are seizure-free 2 years post-surgery, which is very good. The ones, my patients who are not seizure-free, and we expected them not to be seizure-free, are the ones whom we did palliative surgery for. So for example, a child with tuberous sclerosis who has the drop seizures, and then who has the focal seizures, the big seizures. So all the drop seizures that were dangerous for her, for example, because she would always fall at school or at the playground, after we did the corpus callosotomy, they stopped. But she continued to have the focal seizures. But it's less frequent than before. So that's good. And I just saw one of my temporal lobectomy patient who is now 19, and I tell him, okay, I'm going to transition you to adults, and they're always fearful. They're like, no, I'm seizure-free for 2 years, I don't want to go. But that's part of our job too, is to guide you to go into the adult world. And so it takes me about 2 years, 3 years to transition them to the adults. So I help them find an epileptologist that they get along with, that they can be compliant with, and then they transition by the time they're 21. Yes?
What steps should surgery be looked into? Is that like right away we should look into surgery, or is that something that should be left?
I think that's a very good question, especially for parents, because they see the child and they think, my child is going to have such a long life. Why do I want to jump into surgery? But studies have shown that if your child is an ideal epilepsy surgery candidate, so number one, your child has epilepsy. Number two, your child has drug-resistant epilepsy. And three, what helps is if there is an abnormality, for example, in the MRI that you could go after in surgery. Then, or if they do additional studies like PET scan or what we call ictal SPECT scan, so they basically make your child seize, and then they have to inject within 20 seconds from the seizure onset, so they could tell where the seizure is coming from. So if all this data fit together and it tells you, for example, certain lobe, let's say the temporal lobe, that's where the seizure is coming from, on the right temporal lobe every single time, then what we do at our center is we present the patient at the epilepsy surgery conference, and it's attended by the child's primary neurologist, the other epileptologists, both peds and adults, the neuropsychologists, and the neurosurgeons. And we discuss the case. We ask questions. It's almost like a courtroom. It's like the person who's presenting is trying to convince everyone that this is the best course of action. And we show the EEG, the MRI, the CT scan, and sometimes I do some computer processing where I merge the MRI scan with the PET scan, or the MRI scan with a SPECT scan. So you could actually see in a picture, this is what lit up. This is where the seizure is coming from. So if everyone is convinced that yes, we could do surgery, then it's reasonable to move forward. But sometimes there's some debate, some seizures are coming from the right, let's say 40% on the right, 60% on the left. So we need more information. So sometimes we do what we call intracranial monitoring. So either we do the stereo EEG, where we put in the electrodes through the brain, or we do a grid, we put in a grid or a strip to know exactly where the seizure is coming from. So it's kind of like an EEG, except you put the monitors directly on the brain itself. And then once you see the seizures, you see where it starts, you see where it goes, where it ends, then you could convince yourself it's coming from that location. So if we take out that area, surgery will be helpful. So I urge families, if your child has failed adequate trials of medications, and if there is a syndrome, then all of that has to be taken into account for epilepsy surgery.
Are those high risks?
So it depends on where the surgery is. So one of the most common questions that I always ask for older children is the child right-handed or is the child left-handed? So let's say if the child is right-handed, most of the time, about 80% of the time, language is coming from the left side of the brain. So if you have to do surgery on the left side of the brain, you have to consider that you may affect the language of that child. Or let's say in the temporal lobe, you may affect the memory. But if you balance the risks of the surgery and the benefits of seizure control, the risk of sudden death from epilepsy, but the benefit of better seizure control and developing normally, I think parents eventually get to that point. But it takes a while, which I understand. I've had a patient who was worked up at UCLA. UCLA said the child is a surgery candidate, came to us for second opinion, we agree. Child is a surgery candidate, but the parents are scared, so they don't want to move forward with it. So I give them the information that they need. I offer them to meet the neurosurgeon so we could address their concerns. But if they don't want to do the surgery, we're stuck. So it's sad that, even earlier, below 18, we already know they're ideal epilepsy surgery candidates, but then they don't pursue it, so it doesn't happen until later when the child can decide for themselves. Any other questions? That's a long-winded answer.
Are
Yes.
all programs that, do they go through that many measures before they go through and move on to surgery, or do some schools or medical office or hospitals go a little faster on that?
I think that's the model that we used, right? Because at Emory we did a lot of surgeries because it was the main center in the South. So we had pretty much about one surgery a week on the adult side, and then one epilepsy surgery on the pediatric side. So it was very busy, and so I was used to that model. And then when I came here to California, it's a lot less. It's I think because we don't do as many, and parents decide either to try the next medication that comes out. So I used to joke, I'm losing, some patients wait 2 years or 6 months to 2 years for Epidiolex to work. But then on the flip side of that, you have sudden death from epilepsy. You may not have that time to wait. Yes.
Kind of 6 months into this, we have a neurologist, but when or how do you get an ophthalmologist?
An epileptologist? Okay. So epileptologists are fellowship trained in epilepsy. You start with your insurance and see who they're contracted with. That way you don't have to pay out of network. And then they usually work in comprehensive epilepsy centers, because that's where we have the resources to get all the imaging that we need, to get the EEG monitoring that we need, and all the advanced technology. So preferably go to a comprehensive epilepsy center.
So at Loma, Linda, how much do you all work together? So she was at a general neurosurgeon, her daughter, and she's 16, so she's transitioning, and she's now coming over to Loma Linda later this month. So now, as we're learning all the different roles, how well, A, in a general sense, does it matter who we see? Or once you're in the system, it's better than not being in the system? And then B, once she's in, if she's not seeing an
Epileptologist?
Epileptologist.
Or you're going to work with her anyways, or she'll be referred to one?
Does she have CCS?
What's that?
California Children's Services? Because I know you see Children's Services, it's like a form of additional insurance.
No, she just has Cigna.
Cigna, PPO, HMO?
She's okay with that.
HMO, okay. I would, is this recorded? So for California residents, for children who have children with epilepsy, it's better to enroll in CCS because a lot of the center, I know UCLA and Loma Linda are both CCS epilepsy centers. And as you know, epilepsy takes a lot of care, it takes a lot of studies sometimes to get the answer that we need, and it can help get everything expedited. But that's only good up until they're 21. After 21, they transition to Medicare.
Do you know how many types of epilepsy?
It's infinite. It's infinite, yes. Right, because you can have one child who just has this one type of epilepsy and you add that.
So many things.
Right. So the general breakdown is generalized epilepsy, and then the other one is focal epilepsy. And then under that focal epilepsy, you have different types. And then under the generalized, you have different types. You can have myoclonic, you can have, we have children, for example, that has the drop seizures. You can have astatic epilepsy. You can have the most common one, the absence epilepsy. But even the focal epilepsies, it sometimes depends on where the seizures are coming from. You can have syndromes, Panutopoulos syndrome, for example, where it's mostly coming from the back. And the occipital lobe, you can have the temporal lobe epilepsies, and what we often see in children is the frontal lobe epilepsy. So this is where I think it's important to have a child pediatric epileptologist, because the types of epilepsies that you see in adults may be different from the types of epilepsies that you see most commonly in children. And then there could be syndromes that are associated with the epilepsy in the child.
Is it common for the seizures to change, or do they become additional types? So, for example, she started with the absence seizures, and then now she's had the tonic-clonic. So is it a matter of it went from one type to another type, or does it both were already there, they just manifested at different times? Or is that a pattern that it goes from?
So it depends on what type of syndrome. So even with the big umbrella of epilepsy, you could also have other types. One is genetic epilepsy, the other one is structural epilepsy, another one is metabolic epilepsy, depends on how we process the food we eat, for example. And then there's always this unknown, right? Because we don't know. So I'll give you an example. For example, in West syndrome. So most of these kids below 2 years old, starts usually around 6 months. They're normal up until 6 months, and then 6 months they start to have the spasms. And then they start to have developmental regression. And then around 2 years old, they start to have the generalized tonic-clonic seizures, and then they also have focal seizures. So now they transition into Lennox-Gastaut syndrome at 2 years old. So you have other seizure types coming on. So I think the thought process has changed, especially in pediatric epilepsy, that the genetic component, the metabolic component are pretty, it's helpful if we know what they are and we know how to treat them. So when I was training 4 years ago, they used to joke at me. They said, "Why do you want genetic testing? You cannot change it. What if the child is a surgery candidate, just do surgery." That's what my mentor told me. Why do you keep seeking answers? Why do you keep looking? And I said, well, I want to know if there is a genetic abnormality that could explain the epilepsy, that could explain, let's say, the autism, the other features, because I could counsel the parents and I could tell them, look, I can treat your child with surgery, but I cannot change the autism. I cannot change their behavior. It might not get better. So it helps us have realistic expectations.
And also, when it is genetic, it can, if they have another son or daughter,
Right. So for genetic counseling,
you have to know if it is, I mean, it's better to know.
right, I think it's better to know. Sometimes we never know because we call this variants of uncertain significance. My nurses are here and they order the studies for me, and then they come back and it says variants of uncertain significance. So I go down, I read the footnotes, and I see, okay, what are the articles out there where this variant of uncertain significance has been seen in children with epilepsy. And I actually sit down and look for these papers, and I see if these patients have common symptoms as my patient. And then I explain that to the family. And sometimes the insurance will cover, or the lab will cover testing of the parents. So I do testing for the parents as well. And if they don't cover it, I ask the parents, do you want it? But it's such an evolving thought and process right now, but I am an advocate for genetic testing if you're suspicious that there is a genetic cause. But of course, if you know it's a structural cause, if there was a stroke or if there was a tumor and the child was normal before or the patient was normal before, then you don't go looking for that if you know that there's really a cause. So, and in answer to your question, it would be best if you see an epileptologist. Whether you go to Loma Linda or somewhere else, it would be best to go to an epileptologist. A pediatric epileptologist.
So when you say pediatric, are you just sticking with the legal term of age 18 and not the way it's going to be? Because she's tall, she's 16.
She's 16.
She's taller than I am.
Right.
She's
21.
an adult, and so the medication and her weight and her height is going to be adult level. You still want to stick with that pediatric?
So it's below 21 years old. That would be under pediatrics. Yes. Yes.
Okay.
It doesn't matter how big the child is, how heavy the child is. It's the age below 21.
Okay.
Right.
All right.
Yes.
Is there a group here for the Loma Linda?
Yes, I don't know if they're still here, but I think I have some flyer. It has the contact information for adult and peds centers. So we have two, the head of the neurosurgery for adults is an epilepsy neurosurgeon. So he was actually one of the original guys in North America to use the SEEG. You could Google him. His name is Warren Bowling. So he's a co-author on the stereo electroencephalography textbook, because they started it in France, and then they adapted the technique in Montreal. So I think we were one of the first centers in Southern California about a few years back to start the SEEG. And he's very stereo EEG focused. And then we have two pediatric epilepsy surgeons. One is Dr. Robison. He used to be at CHLA. He's now with us. And I believe there's another one. I don't know his name. He just started. So, but they're excellent. I think one of the advantage of the place is if you have a collegial atmosphere among the epileptologists and the neurosurgeons between the adult and the pediatric side. That way you could all learn from your case. So.
I have another question. But
Sure.
I don't know if I'm going to say it right.
Okay.
In my sister's case, the first seizure showed at 6 months.
6 months?
But it was the first time, and well, when she was born, she had like I don't know how to say in English, cyanotica. Like,
Cyanosis? Okay.
so, but it showed until the first at 6 months.
So 6 months, first cyanosis as the seizures, and they were shown by EEG to be seizures. And then how long did she have seizures after 6 months?
For a year.
So for a year. So she continued to have the seizures with cyanosis for 1 year?
When she was born, she was silent.
She was cyanotic.
And that happened in the moment of birth.
Okay.
Everything was right. And then at 6 months, the first seizure
Appeared. Okay. I think we need to go back to the birth history, try to find out what was the reason of the cyanosis. And then was there any head imaging during that time? And was there any change in the brain during that very first episode? So I always ask the first episode. And then the pattern of intractability. So if it started at 6 months and continued on for 1 year, how many medications were tried? How many worked? How many did not work? And what was the longest seizure-free period? So if the case is 1.5-year-old seizures and then up until 18 years old, so you have about 16.5 years of seizure freedom. And then at 18, the seizure comes back. So in that instance, you ask the question, was there an MRI at 18? Was there any abnormality in the structure of the brain at 18? Was there a family history of epilepsy? And is it a similar pattern? And what is the EEG pattern? So the basic question that I think we sometimes miss is it epilepsy or is it not epilepsy? Because if you tell me it's cyanosis, it could be anything. It could be ALT without previously known, like, when children just stop breathing. Maybe the child passes out. So I don't know if it's cyanosis. So seizures, they have a pattern. Beginning, middle, end. And they're also paroxysmal sometimes. They happen with certain triggers. In women, they happen cyclically. So a lot of this history is important to know. And we don't know, was your sister actually seizing in between? And we just don't know because we didn't check, right?
What about in adults that when the first time appears, is it has to be because of an accident or just because?
It could be just because we see it. So we call it juvenile myoclonic epilepsy. We see it in teenagers, we see it in adults, and it just happens, right? But there is a signature pattern to it on the EEG and on the seizure type.
So once it happens, then is when you have to look for answers.
Right. So 2 unprovoked seizure or seizure-like events, they have to be worked up. Number 1, you have to answer the question, is this a seizure? Number 2, you identify the triggers, see if avoiding the triggers prevents the seizure, and then you treat. Right. And it's almost like a habit for me now that I do an extensive history. Takes me 1 hour to 2 hours the first time I meet you. I get family history, and then I do a head imaging, and I review the previous EEGs, and then I also review the videos that the families take because those are helpful. Do you have the videos? No, I'm just kidding. I heard she's like, do you have the videos? Yes.
Yeah, can
No.
we switch? Would Dr. On be willing to just pop us over to you?
Have you seen him already?
No, the 20th.
On the 20th? Why don't you see him and see how things are? And then if you want, you can ask to be referred to me.
Is he amazing
then-
like you?
Oh, you're so nice. I mean, he was my program director when I was a resident.
Okay.
Yes, so I learned, his specialty is demyelinating. So like multiple sclerosis, that's his specialty.
The MS. I noticed all the our daughter
Right.
does not have MS.
Right.
Our daughter has absent seizures.
Absent.
That's
Okay.
it. Like, that's it. And so I'm looking at MS going,
Right.
I don't think it's a fit, but you people are really hard to get into. So 4-week appointment out, we get the 20th of November.
You get him. Just and have him. How many medications has your child tried?
She's tried, so the basics are, we've killed Topamax. We're back on Depakote
Okay.
as a 16-year-old girl, and I
Okay,
heard that's
16.
not good.
It depends on what
she's on
type of
Keppra.
seizures. Keppra. Okay. So you're 3. You're in the drug-resistant epilepsy category. So I think Dr. An will be open to referring you to an epileptologist.
Oh, good.
Yes.
Okay. And we're sorry. Are you an epileptologist?
I am. Yes.
Oh, we'd rather have
Yes.
you than Loma.
Pediatric. Yes. Unfortunately, I mean,
Unfortunately, I'm booked up until January.
Yeah, so is Loeb. Yeah. Yeah.
Yeah, we
Okay.
just found out today that her EEG says that she doesn't have any epilepsy, based on the write-up on the book. So it's
We're just coming from a very incompetent
Okay.
office. And so we're excited to come to Loma Linda.
I'm sorry.
We're
Well,
assuming you have your stuff together.
we try.
We hope. It can't get any worse.
Right.
well. So the last punchline is
We'll try our best.
Oh yeah, when
you
he
should tell
referred
us.
it, when he referred us to Loma Linda, he said he's referring us because we need to be seen by a professional.
Any other questions that I can help?